Good evening to all of those of you who have joined us already, and thank you for joining another Daily Maverick special webinar looking at aspects of the COVID-19 crisis in South Africa. Thank you right at the outset to PPS Health Professions Indemnity for making this webinar possible tonight and providing sponsorship. And thank you too, right at the outset, to our two special guests who have literally taken time at a very difficult time off from the front lines to be part of this webinar and to come and share experiences and observations and ideas about how we tackle the deepening COVID-19 crisis. So if I can just introduce them to you very quickly. Both have very long CVs, and as usual, I'm not going to take time by going through those CVs, but the first person I'd like to thank and introduce is Professor Nathi Mdladla. Professor Mdladla, Nathi for short, is the Chief Intensivist at George Mukhari Academic Hospital, as well as at Sefako Makgatho University. Thank you very much, Professor Mdladla, for being with us this evening. The second guest is Professor Jeremy Nel, who's also another doctor very much involved in the front lines of this crisis. He is the head of infectious diseases at Helen Joseph Hospital in the center of Johannesburg, literally at this moment in the eye of the storm, because if Gauteng is becoming the eye or the epicenter, then central Johannesburg and the hospital in which Dr Nel works is at the center of the center. So thank you very, very much to both of you for making this time, at this difficult time, to be with us. The subject of tonight's webinar is Gauteng, the crisis in Gauteng. And although it may seem perverse to say this, the webinar could not have come at a more pertinent and unfortunate time. If you looked at the headline of City Press today, I think it's a sensationalist headline, but nonetheless, COVID death storm is here. Is what it says, and much of its reportage is about what is happening or is about to happen here in Gauteng Province. As we speak, in less than 2 hours' time, President Ramaphosa will once again address South Africa, and I think that his address is a reflection that we have reached a critical moment in the COVID-19 epidemic. We're no longer talking about a theoretical danger. Our discussions have moved from testing to treatment and care and issues of mortality. It is very, very much upon us. And as I said, we will hear from the president later this evening. But let's get this conversation this evening going. And I want to start with you, Dr. Mdladla. Can you just take a few minutes to explain to us why it is that Gauteng has become the heart, the epicenter of this epidemic, and what do you think are the particular challenges that we are going to face over the next few weeks? And obviously, base your comments on your experience as an intensivist at a hospital just to the north of Pretoria. So if you could kick us off with your thoughts and your observations. Thank you.
Thanks, Mark, and thanks for having me on this webinar. I want to share sort of our experience, and I think one has to go sort of further back. And one thing that we need to be aware of is that, in fact, when we started our hard lockdown, sort of end of March, that we, especially in the intensive care community, we all expected that the peak in South Africa will hit us around about June, probably escalating at about July, and really probably reaching sort of the flattening or top part of the peak at about August. And the disease really has behaved as was expected by probably most people in that type of sphere. Now, Cape Town, when the storm hit Cape Town and everybody was wondering what Cape Town did wrong and what had they missed, it was also probably missing the true picture as well of our sort of flu season in South Africa. So it is known and has been known from before that Cape Town is actually indeed 2 weeks ahead of Gauteng in terms of the peak of their flu numbers in normal regular flu season anyway. And so with COVID, that was also to be expected. So the initial escalations in Cape Town were not an anomaly and actually something that was expected. And also in Gauteng, we prepared ourselves that it is going to follow either within a similar period of 2 weeks or longer. And this is actually what we're expecting now. And as one progresses through the country, the similar trend actually has been happening. There's been a predictable picture. From my part of the world, which is northern Gauteng, border of the Northwest Province and the north of Gauteng, we've been typically about a week in terms of cases seen, in terms of admissions, and in terms of the severity of cases that have been presenting to Gauteng, for example. So we're predicting that in the next week or two, that part of the world will start seeing its surge. And there seems to be a progressive increase with the disease. And if one also looks overseas, the same trend has been happening. Through the US, there's been a movement from the east going straight to the west coast and delay with presentations in those parts of the world. And that's why we're seeing the higher numbers there. So there's definitely a progressive migratory pattern to what we're observing with the disease. Now, when it comes to sort of, again, our part of the world, now asking why the surge is happening in Gauteng, one apparent thing that we all should be aware of is firstly the fact that we've never been really on lockdown except for sort of government regulations or restrictions per se. But in terms of people and population lockdowns, we all know that actually that has not happened in the sense that it should have happened in. And as we're getting now also to the colder months, which force people to even be less able to move around, those restrictions, physical distancing in particular, becomes less and less possible to actually maintain. As sort of information then to people in the province is that we also need to be aware that we've done the reverse of what the rest of the world has done. So we've gone from hard to releasing as we actually move into the eye of the storm, as it's been called, or the hard part of the disease, which is actually in the reverse to what the rest of the world has done. The rest of the world has actually gone higher with the impending threat and increased restrictions with the impending level of danger that's been happening. And we've done the reverse. So the escalation that we have really is in line with our strategy that we've assumed as well. And practically, as I would like to say, that we're practically behaving like Sweden, if you want to put it sort of more aggressively. So we practically do not have restrictions. And we are going to see these high numbers. So that is my take of what's happening in Gauteng.
Well, before I move on to Dr. Nel, so we're expecting the president to speak this evening, and there have been calls from the provincial government in Gauteng for the reintroduction of a stricter lockdown because of these spiraling numbers. Would you support that, Dr. Mdladla? Do you think that is the right thing to do, or is it too late to do that, and should we be concentrating our efforts in other areas at this moment?
It's definitely not the right thing to do at this stage. I think where we are now, we have lost control of limiting sort of further spread. The disease is already endemic in the population. It's taken its own course in life, and there'll be little gain we're going to have with a further lockdown. But the damage that's going to cause in the long term, it will be much more significant than actually not going into one. There can be probably modifications in what we do to limit then perhaps emergency admissions, if that's the target. So there'll have to be focused things that we'll put into place to intervene. The issues around probably alcohol patches, which I do not necessarily believe that just limiting how it's patches is going to help, but maybe there might be a strategy. But definitely going into an escalated lockdown, I think we stand to lose more than actually gain from that.
Okay, thank you. We may come back to that a little bit later in the discussion. Dr. Nel, Helen Joseph Hospital, Central Johannesburg. What are you seeing, and how do you understand what you're seeing?
Thanks, Mark, and thanks for having me. I think at the moment, the hospitals in Johannesburg and around the area are just about managing to cope. We're sort of groaning and creaking at the seams a little bit, but we are holding fort at the moment, and it's not currently a disaster. But I guess my big problem is I'm wondering where it's going to go in the next month, and I think all indications are that this sort of epidemic, and certainly in Johannesburg, is predicted to peak somewhere in the middle of next month. And the amount of beds in particular, and in particular oxygen delivery beds, and beds where we can provide oxygen to patients, are expected to be under enormous strain. In fact, be totally overwhelmed with the current levels of beds. So, there's, just to give you some sort of idea of the numbers, obviously the predictions vary, and obviously they're subject to a lot of variables, such as how the community behaves and what sort of lockdown levels we have, etc. But I mean, just optimistically at the peak, we're looking at, in Gauteng alone, maybe 15 to 40,000 extra beds, beds required, rather, for COVID. And that's the optimistic side of the picture. I mean, Gauteng's own numbers put it somewhere between 65 and 80,000 beds by the middle of next month, just required for COVID. And to put that in perspective, the entire of Gauteng only has about 30,000 beds at the moment between the public and the private sectors. So clearly the number of beds that we require for COVID, and that's obviously those beds, the 30,000 in Gauteng, is for everything, including non-COVID things. And in winter, for example, in the state sector, we're almost always at 100% capacity anyway in Gauteng. So clearly the beds are going to be a massive issue. And I think that it's not just the beds, as we know, because there have been a lot of moves to expand the number of beds, but it's the sort of beds where we can provide oxygen. And that's really critical, because of the people who get admitted with COVID-19, maybe 80–85% of them at a minimum require oxygen. Most of those people just need simple face mask oxygen. So you give the patient the mask that you see on ER in the ER, just something to cover the mouth and to give them a bit of extra supplementary oxygen, and they generally do fine. Without that oxygen, though, they will do terribly. And so it's an enormous pool of preventable deaths if we can get the oxygen delivery right in Gauteng and beyond Gauteng, in every province. There's some which require ICU beds, and Nathi's a better expert at that than me, but the number who require critical care beds is a small number relative to the number who just require simple oxygen. And it's not an easy thing. You can provide a bed, but to provide oxygen to that bed requires often piping or oxygen concentrators in huge numbers. And we're dealing with thousands of extra beds that are going to require this. You need nursing for that. You need the doctors. You need medications for all of that. And that, to me, is the big concern going forward. I think that as a middle-income country, we're not going to have, it has to be said straightly or flatly, we're not going to have enough ICU beds for everyone. We didn't have enough ICU beds before COVID. We're certainly not going to in COVID. Despite, we'll try as much as we can to expand them. But what would be an absolute tragedy for a middle-income country is to not have enough simple face mask oxygen for all of our patients. And I think that's something we should be able to get right if we get it all right in the planning. Thanks.
Sure, you've given us a lot to unpack there. Beds, if I understood you, you said we need anything between 15 and 40,000 additional beds.
Well, those are the beds predicted for COVID, some of which will be by the existing infrastructure. So we'll need fewer additional beds, but still the additional beds will be in the thousands, yes.
Yeah, and oxygen is a critical thing, and obviously personnel, healthcare workers to manage this surge. I mean, from what you're both saying, and interestingly, as Nathi was saying, although we're only 70 kilometers, your hospitals are only 70 or 80 kilometers apart, this wave is going to reach them at different points. But from what you're saying, we're not ready for this crisis. I mean, we're working as hard as we possibly can, but it's a fairly bleak picture that you are presenting. What should we be doing now, Dr. Mdladla? What are the critical interventions needed now that will help save as many lives as possible in the next in the coming weeks and months?
So before actually answering that, there is another picture probably one needs to paint, and I think you've touched on the fact that we're possibly not ready, and actually that has to be put up front. We are not ready. There has been capacity being built. Just as an example, so in our own hospital, which was initially not a COVID designated hospital, and we eventually were designated as such when it became apparent that it was going to increase around about May. We literally had to close down half of the hospital to convert it to being COVID ready. So now that's where we're coming from. That part of the hospital is only 40% functional at the moment, or that part of the COVID section, with the various issues that comes with it. Secondly, is the issue of testing. So right from the beginning, we picked up the fact that testing was going to be the biggest cause of the bottlenecks in the system. And that hasn't caught up until now. Actually, if anything, things have gotten worse in spite of the various changes and strategies that actually have been implemented. And for our setting specifically, it is causing probably the biggest issues. Up to this stage, we probably have more COVID negative people or patients under investigation dying waiting for a COVID result than we have COVID patients dying positive. And that's just because of where we are in the trajectory. And the issue of testing is probably the biggest bottleneck. Until then we get the capacity reached for the other parts of the hospital, which is going to be a 300-bed ICU, we actually don't have anywhere to go. So for myself, the first part that we need to get right as we're heading to really the nasty peak of this is that we need to put into place the contracts and the negotiation that we need to have with other players, especially outside testing, although private is also starting to experience the challenges, but they are still better than us. So outside testing will actually help us in a big way. And this needs to be facilitated and done as of probably tomorrow to have those contracts done. The next thing is actually also negotiating with private institutions in terms of accessing their extra capacity in terms of beds and available ICU space. Now, I don't think that solution can really be solved, especially for the hospitalized patients, by the field hospitals and the other facilities that are being built. That has to be done in places where the staff are, the doctors are, the equipment is, and all the necessary interventions can be done. So we need to also get that into place. I think Cape Town taught us that lesson, and we've delayed activating that process far too long. When we actually learned from Cape Town that actually might be the solution that we need. So we need to get that part of our strategy in line, because we are actually going to need that help. When it comes to the extra resources with high flow nasal oxygen, which is where we are going, the problem that's happened is that because when Cape Town got involved first and the private hospitals, all stocks of high flow nasal oxygen were actually depleted in the country. So anybody who's trying to get into that space now cannot get that equipment. We started procuring this around about April, and our stocks, some of it's only arriving now, and some of it is still delayed probably until August. Some of the private institutions already have these things. So if it's either we borrow from them and actually use it in our own setup, or we actually send patients there. And we do not have the same capacity in terms of staff as well. So those are the challenges, and that's what we actually need to get ready and put into place to effectively, in my opinion, maximize the resources that are available in the province to manage this challenge.
Okay, so if I'm hearing, testing remains critical, pardon me, because people are being diagnosed or not being diagnosed and not getting the treatment as a result of delays in test results coming back. Integration of public and private to have one system responding to COVID-19 rather than two systems working in parallel, and one system carrying most of the weight up to now, at least. And you give the example of the Western Cape, what was done there, and oxygen. We keep hearing about oxygen. I may come back to the other issues, Nathi, in a minute, but Jeremy and Nathi, can you explain why oxygen has become the game changer, it seems to me, in so many ways? Can you explain to a more lay audience why it's so important and what are the challenges going to be? And can you also explain this term high flow nasal oxygen, which is something that many people are seeing as a kind of something we've learned in the course of treating people as a way of avoiding intubating patients and keeping more people alive. Jeremy, would you mind? And feel free, of course, if there's other things that you want to respond on.
Sure. Yeah. Thanks, Mark. So, I mean, this is mostly a respiratory disease, COVID-19. So, most of the problems that happen and most of the issues that patients run into is related to the viral pneumonia that they get. And for that, the number one form of treatment is oxygen. Now, there are other things we do in hospital now. Those patients who need oxygen also get medications like dexamethasone. They also get an anticoagulant, which, like heparin, which you may have heard of. But in essence, the key thing is oxygen. So without oxygen, the rest of that is really sort of arranging deck chairs on the Titanic. So the most important thing is oxygen. That, like I said, about 80, maybe 75% of the people who get admitted to hospital just really need face mask oxygen and don't require an ICU or a high care bed with anything like high flow nasal oxygen or anything similar to that. The problem with this is that at the peak, the amount of oxygen required nationally and provincially will exceed anything the country's had to do before. And so that requires a lot of extra planning ahead of time in order to ensure that that demand is met. Because like I said, really that for me is the key thing. I don't want to see any of our South African compatriots not being able to access simple face mask oxygen at the peak. I think that's something we can achieve. And like I said, I must acknowledge that, I mean, I do think there's an understanding of that by the provincial and national governments, and they are working very hard to do that. And I think in the last week, we've seen a lot of improvement in the communications, and they really do seem to be putting a lot of effort into getting it right. I just hope it's enough in enough time is really the issue, because we've known this peak was coming for a while, and it's really, at the moment, we're meeting demand more or less. We have to get that right. And with the oxygen, for example, it's the little things, like, for example, are there enough oxygen trucks to deliver oxygen at the peak? Are there enough oxygen cylinders in the hospitals capable of delivering oxygen in the hospitals or clinics? If you, for example, if we have 100 oxygen ports where you could access oxygen, they're not normally accessed all at once in any particular hospital. If you switch them all on, like we might have to in the middle of a COVID pandemic, will that system hold, or will the flow rate drop because we just don't have enough oxygen coming through the main port? So it's all of these kind of things. It's not just a case of, like I said, putting a bed out there. It's a complicated system, but it is something that is achievable, and I really hope we can get there. As for high flow nasal oxygen, I'm going to defer to my colleague because he knows much more about it than I do.
Okay, Nathi, but just before we go to Nathi, how do we know as the public whether we're making progress on this oxygen question? Do we only know when doctors like yourself start screaming, we don't have enough oxygen? I mean, are there systems? Is there a reporting system that allows us to see progress government and the private sector is making so that we can be sure that we're getting ready?
There are indicators, and for example, like I said, at the moment, we haven't run short of oxygen in almost any of our facilities. So I think, like I said, at the moment, that number's holding. It's more just a case of projecting and saying, how many oxygen beds are we going to need at the peak? And how many are we going to need at each stage before the peak? And matching that to the amount of oxygen beds that the province has. And I think that's really the key indicator. And the question we have to keep asking is, if we're expected, say, in 2 weeks' time to require 7,000 beds with oxygen or 2,000 beds with oxygen, how many of those are ready? And that's really the key issue. It's not an easy number to get.
Okay, thank you. Dr. Mdladla, high flow nasal oxygen and other related oxygen matters.
Yes, so the disease is actually more a spectrum than a specific one entity or single entity. So there definitely will be patients that need to be ventilated. And speaking to colleagues in private, because the private numbers are already way above the state numbers, they're seeing more higher cases coming in, sicker, and it needs to be managed. And in some institutions, actually ventilating. The challenge is that, as I said earlier, not all of them manage to procure these fancy high flow nasal cannula setups that are now the preferred method of oxygen management or oxygen treatment as we've learned from overseas. So the whole high flow nasal cannula or nasal oxygen setup actually comes from New Zealand and Australia when they experienced the H1N1 high pandemic back sort of around about 2009 and so on. And they learned to use this particular modality then. And interestingly, when COVID came, initially high flow nasal oxygen was actually contraindicated because the feeling was that it actually spreads viruses and actually probably puts people at risk. But the New Zealanders actually stuck behind it. And we've also learned, and Cape Town has actually published their results and experiences on it and proved that actually the outcomes with using high flow nasal oxygen are actually better. So it is deemed as a non-invasive type of ventilation and actually allows patients to breathe a bit easier as if they were actually being ventilated, but without actually necessarily getting the tube in. And the outcomes within these patients, you can start it earlier and manage patients with it. And definitely the outcomes are way better than they are in patients that are actually intubated. But there is a subset of patients and actually people that are intubating people who deserve to be intubated, who have actually shown probably almost similar results. But as in terms of just looking at numbers, the people that do really well with their patients that are intubated, they probably will have about a 50% positive outcome. Whereas on patients that end up on just high flow nasal cannula, they're actually seeing probably upwards of 80 and higher percentage of success using that particular modality. Now, for our reality, the fact is not everybody's going to have it. As I've said, the stocks are coming from overseas. They've run out in the country. Every company that supplies them has run out. The stock that's being ordered is coming in dribs and drabs. So most centers will actually not have it, and that is a concern. It tends to consume higher levels of oxygen than normal low flow oxygen. As a number, for adults, you're running between 40 to 60 liters a minute of oxygen, whereas the low flows, you're running anything between 6 to probably 10 liters per minute. So they tend to deplete your stocks very rapidly. And you need to, as Jeremy said, have means of monitoring this or keeping an eye on it. The private hospitals, they've set up these networks, keeping tabs, communicating availability of stock, and topping up as necessary. And I think public hospitals need to do the same. The capabilities are not the same everywhere. And the know-how in some of the hospitals is not probably as organized. And that's something that the province is going to have to look at aggressively and ensure that the DID or the infrastructure development departments in the various hospitals are cognizant of what running these high flow situations will do to the system.
So it's going to need a lot of efficient oversight and coordination. Just two related questions. In fact, I read somewhere a report, it may have come from one of you, that a lot of patients are arriving at clinics or at hospitals hypoxic, i.e. they've allowed their oxygen levels to deplete dangerously low without knowing it. Is that true? And do you think that there's enough at this moment kind of public understanding of COVID-19 disease and when you should be seeking care and when you should be worried and so on? Is that a problem, Jeremy, that you're seeing, or did I get it wrong completely?
No, that's certainly been reported, and I think that there's two reasons why that can happen. The first reason is very difficult to get around, and that's that with COVID-19, some people, for reasons we're unclear of, but some people are what we call the happy hypoxics. In other words, their oxygen is low in their body, but they don't respond to it like they would if it was any other pneumonia, where you feel short of breath and you feel like you're really gasping for air. In other words, you tend to tolerate it at home for a lot longer for unclear reasons. But that means by the time it gets bad enough to get to the clinic, by the time you get there, your oxygen is often very low. And that's very difficult to get around because it's, the patient may not know. And so certainly, what we'd say is any deterioration in your ability to function and do the sort of things you'd normally do with exercise or with lifting heavy objects or even just moving around the house is certainly a reason to come into the hospital. Another reason, though, for coming in late and for having low oxygen when people do present is that they're scared of the hospitals at the moment. They've heard it's overfull. They've heard that they could get COVID, even if they don't have COVID now, they might get it at the hospital. The hospitals are so full that it takes a long time to be seen, understandably. Again, everyone's working very hard. It's not a criticism of the clinics or the hospital. But I think, the people present late because they're scared of the hospitals. There's some degree of denial as well. People are scared of COVID-19. And then that other reason is that some are just happy hypoxics. That's a much harder group to deal with, though.
Thank you. Thank
And
you.
and
then just one, sorry, Nathi, yeah, go.
So I'll have to agree with Jeremy on those points. And my take is almost that we need to almost do reverse education. So in the beginning of the pandemic, when we were trying to get compliance, I think we spread the fear message disproportionately to the education message. And Jeremy says that the delay in presentation is partially because of that fear that we cause trying to achieve compliance, which unfortunately has a negative effect of people delaying consultations for as long as possible or until they're actually not really in a bad state. So we almost have to reteach people that this is a serious disease. The people that do get significantly sick really do badly. But at the same time, in terms of the balance of numbers, it is actually a disease that probably is not as lethal as the media would like us to believe that it is as lethal. And similar patterns of medical consultations need to be followed to maximize and limit sort of further damage. And I think we need to actually embark on this reverse education angle together with stigma removal of the disease, which I think slowly we are achieving. I think communities are starting to learn that positives are positives, and the state is starting to learn to live with this. But we need to actually then deconstruct again the fear aspect of this.
So you would probably both agree with me, because the media must have an important role at this point to report accurately and to report sensitively and not to spread panic and fear. I mean, when I saw this headline in City Press today, COVID death storm is here, I found it unfortunate. We can report on COVID without creating panic. Would you share my views on that?
Yeah, definitely. Yeah. If I were to start, definitely I would. As an example, I think in my workplace, every start of the morning on the ward round, the first point of call and check-in with the staff is actually deconstructing the fear. Unfortunately, the headlines that perpetuate in the media, they undo whatever you say on one day, but the following day they come back and they say the numbers have increased by this much and this has done this and so many people are dying. So you almost have to redo on a daily basis just to get people to feel comfortable to work in the space. And this has been, in terms of the service or the frontline workers, has actually been and had a significant negative impact and probably increased mortality as well, because staff are scared of even getting involved in these patients. And so the positive message and actually painting the true picture, this will actually save us more patients than sort of the hyped and sort of fear-creating messages.
Thank you. So that's an important message for the South African National Editors Forum, particularly at this critical moment. Now, I want to move on to this question of mortality with both of you in a minute. But before I do, just one thing you said, Dr. Nel, which one of the listeners picked up. You said COVID is primarily a respiratory disease. I've been seeing some questioning of that, and some people saying it's there's a vascular disease. I've been reading reports of coagulation and so on. I know that's probably a complex scientific question to answer in 30, 60, 90 seconds, but can you just point us in the right direction on that question, or point us in some direction before I continue the conversation?
Sure, it's a very good question, and it's a complicated question to answer, partly because no one yet understands it in full. So I do think that certainly the virus can go to many places in the body, and one of the prominent places it does go to is the vessels. And it certainly can be associated with vessel disease as manifest by, for example, strokes or heart attacks or pulmonary embolisms or things like that. That's undeniable. What I was meaning was more just the sort of more layman's take on it, which is really that of all the things it does to you, and of all the reasons to die, most people will die of respiratory failure, not things like strokes, heart attacks, and things like that. They may be associated with that, and it certainly can present outside the lungs with other things, but for most people, it's a respiratory disease from the point of view that oxygen is the most life-saving therapy in most cases. And that's more or less where it is. It may be a vessel disease to some degree, and it almost certainly is. And it may be that those vessels are predominantly in the lung where it affects, and maybe that's why it affects the lung more than anything else. But it's nonetheless absolutely true that oxygen really is the premier therapy for this.
Thank you very much for that. So just moving on, staying on this question of readiness of facilities. We've heard a lot about PPE, personal protective equipment, and shortages of personal protective equipment. And I would imagine that it also has an impact on the mental health care, the fear of healthcare workers that Professor Mdladla was talking about a minute ago. Have we sorted that problem out? Can we cross PPE off our list of concerns and know now that as people like yourselves and your colleagues are marching into this challenge, that you are protected? Nathi, do you want to take that first?
Yeah, sure. I think definitely, even within our institution, where it might have been an issue at the beginning, the province has really gotten on top of that aspect with PPE in the state sector anyway. And I don't think, unless it's being hoarded somewhere or sort of pilfered, but availability is really at a comfortable level that we have. We've tried as much as we could. I mean, we've delayed in our hospital anyway, using advanced PPE for as long as possible, because we knew that the disease was going to become an issue sort of around about June, end of June, as I've said. So we've only started escalating to your N95s and so on in the last sort of 2 to 3 weeks, and sort of high-end PPE. But the stocks are there. We are fairly comfortable that we'll have enough for the long run, but protecting it becomes a crucial step.
Thank you. Jeremy, Central Johannesburg?
I'd agree with that. I think that it's something that's got a lot better as the time's gone on. And certainly at the moment, we do have adequate PPE in pretty much all of our hospitals. It does, like Nathi says, it requires kind of constant vigilance to make sure it's not being wasted and that you've got enough coming. But I do think, to its credit, that the sort of central procurement has helped this by the province nationally. And I do think that, if it continues as it is going, I think that the PPE shortages should, if any, should be minimal. But it's definitely something that's improved.
Okay, that's very good news. And we were just asked a question by a doctor at Chris Hani Baragwanath. The quality of the PPE, again, I've seen some reports, complaints about the quality of the stuff that's being presented to hospitals. Are we fine there?
Yeah, I mean, I think initially when the whole world was struggling around sort of March and April, where a lot of our PPE comes from Europe, actually, and Europe was at the epicenter at the time then, and really not in a mood to export a lot of PPE. And so we've had to get PPE donated and PPE shipped in from other countries. And initially, I think it was, some of it was of variable quality, some of it was excellent, and some of it wasn't as good as it should have been. I do think that's got a lot better, though. I mean, I'm interested to hear what Nathi thinks, but I don't see that as a big problem currently, certainly where I am.
I have to agree. It's the same with us. The level that we're getting sort of proper standard N95s, K95s. The gowns are of good quality. So I would definitely say we're not having quality issues with ours.
Good. Okay. So there's some positives there. Now, just moving on, Nathi, earlier on you talked about integration of public and private. Another question that I have is the integration of the different parts of our public healthcare system. You both work at academic hospital complexes where you have lots of professors on call and you're linked to universities. But South Africa's hospital network is not made up of academic complexes. So will you say a little bit about the readiness of the district hospitals for COVID-19? Because I would imagine that is where a lot of people are going to present, first of all. And also in relation to district hospitals and what perhaps needs to be done to strengthen their capability. Nathi, I know you've been involved with the field hospitals. What role are we going to expect the field hospitals to be playing over the coming weeks as we face up to this surge? Who would like to start? Nathi, over to
I
you.
can shoot. So you just froze there. So the district hospitals and probably the true sort of contribution we can get from the field hospitals, I think, has been missed. And I think I saw one article today that actually called it the blind spot of the epidemic. And I think the sort of more hospital-centric approach that I think all of us have been pushing all along has really blinded us to the capacity that probably exists there. And I think Jeremy touched on the fact that even just simple oxygen will achieve some benefit for some patients. So what's been happening at the moment, and this is where even we get sort of overburdened with really mild cases of COVID, is that the district hospitals, as soon as they get a COVID, because they know that the tertiary hospitals are supposed to be managing the problem, they forward them to us. And that then sort of clogs up the system. Whereas if actually one can build capacity within those hospitals to manage the simpler cases, the low oxygen demanding cases, that might actually allow us to decongest the central hospital, which need to manage the more severe cases. And secondarily, that's probably where now the field hospitals are going to have to come into play. Field hospitals, if you look everywhere internationally. So personally, when the province embarked on this venture, I did not see it as going to be a potential success, simply because you need to send patients where the doctors are. And this is how the field hospitals have failed overseas. In the UK, in London, the NHS Nightingale never got more than 100 patients admitted by the time it was closed after 6 weeks. And the same thing happened in New York with the Javits Center. They probably just got over 100 over the same period and then to close the center. So as hospitals per se, those units do not actually work. And I was glad to hear that there's been an intervention by yourselves and other people to actually repurpose our field hospitals to actually say, take in people who can't self-isolate, people with mild disease who can be managed there, and people with other issues. We're having a bigger problem in our hospital at the moment, being filled with mild COVID with probably other medical issues, which are also not very significant. But they can't be moved anywhere else because the district hospitals can't take them, and there's no other facility to take them into. So that will be the role that the field hospital will play for us. But we definitely need to put more capacity into district hospitals to maximize, again, on sort of mild moderates that can just be on oxygen in those centers and not necessarily congest the bigger ones.
Thank you very much. Jeremy?
Yeah, I don't have much to add. I mean, I think I agree entirely. I think the big issue is, as you say, getting an efficient system between the district hospitals and the tertiary hospitals. Because, like I said, the vast majority of people don't require tertiary hospital care in COVID-19. But conversely, those who do are best managed at tertiary care. So it's a case of getting the right patients into the right facilities and not being afraid to move forwards or backwards between those facilities. But I think that's something that is improving and hopefully will continue to.
Thank you. And then the last question on the sort of medical aspects. Gauteng's numbers have gone up dramatically. I think yesterday the numbers were in the region of 80,000 or something confirmed cases. But for a while yesterday 93,044 confirmed cases. But for a while, people have been questioning the figures on mortality in this province. The deaths recorded by yesterday were 580 deaths. Can you shed any light on that? Are the mortality statistics an underestimate? Are they wrong? And what are you seeing, and what do you think is likely to happen as we progress over the next few weeks?
Yeah, I think so. I mean, the mortality figures when the caseload pushes up, the mortality always lags a bit, and that's because if you get sick today, your chances of dying are greater in the next week and the week after that. Really, of those few people who do get into trouble and require sort of intensive care or something like that. So as the caseload goes up, it always goes up before the deaths catch up to some degree. There's a number of other things, though. I mean, it's very difficult to compare between provinces in general because a lot of the caseload depends on the testing strategy. And for example, in the Western Cape, there's a much more restrictive testing strategy, limiting it to people who are more likely to get sick. Whereas in Gauteng, there's less of a restrictive strategy, so you're more likely to catch more well people. So the sort of ratio between the deaths and the total number of cases is different. There's probably a bunch of other reasons too. And certainly with time, one thing that has become evident as well is that with time, systems have got better at managing COVID-19 people too. So they're better able to triage, they're better able to link to care. And things like dexamethasone and advances which have become known about COVID-19 have been able to be implemented later on. So I think it's an advantage going second, not first, in this sort of thing.
Nathi, go on, continue.
Yeah, no, so I'll also agree with Jeremy on some of those points. And I think well, for me anyway, sort of almost the obsession with numbers is something that I think we shouldn't have had anyway. But I mean, that's obviously my viewpoint. The fact that numbers are going to come was always a given. What we're seeing with the numbers was never a surprise. And this is what one would have expected is going to happen. In addition to the other factors that probably contribute to the low numbers for us, just sort of epidemiologically as well, if you look at risk populations and you go through the rest of the world in terms of the higher populations with mortality. And I think the Panda report that came last week, especially criticizing the Western Cape's models for predicting mortality or from one center, the UCT, were based on the fact that we actually have lower numbers of people over 65, for example. And if you look at the rest of the world, that's probably where the mortality has come from.
Right.
At the same time, South Africa has shown a different picture, and I have to probably concede that point, that we are also seeing a lot of younger people, even in times without comorbidities, dying. So there's probably a different picture emerging there. But we, in my opinion, and that's how I felt from the beginning, is that we do have a smaller pool of the true at-risk population. In Italy, it was generally over 80s. In Germany, it was the same. In Sweden, the same picture has actually emerged. So we have a smaller pool where we can get these higher numbers. But I think what we're seeing now is not a true reflection, and I agree with Jeremy. This is going to go up, and I think we need to be prepared for that. And I think we'll probably settle around about where everybody is, at about probably 4 or 5%, if not slightly higher. And I think that's something that we need to prepare ourselves for.
Yeah.
So the numbers, Jeremy, yes.
Yeah, I was just going to say, so I think Nathi's point is really excellent, and it's the key thing here is that South Africa does have a very young population, and that's got to do with the tragedies of HIV/AIDS and other comorbidities. But relative to other countries, it's very young as sort of average, and so we can expect fewer deaths, really, for that reason above all, because COVID-19 deaths are so strongly correlated with age. We do have a lot of comorbidities though in this country, so it's not just age. We have a lot of HIV, which is a moderate risk factor. So excellent work out the Western Cape seems to support that. We've got a lot of diabetes, a lot of obesity. So there are factors pushing it up. But exactly as Nathi says, I think, at the end of all of this, we'll look back and we should have hopefully a below average amount of mortality because of the really youth of the population. And hopefully also the good work of the doctors and nurses around it.
Will you just explain, I mean, I was listening to Nathi and about the younger population and how that might impact, but I was thinking as I was hearing that comorbidities and our high rates of HIV, our high rates of tuberculosis, our high rates of diabetes, hypertension, and so on. And from what I can see from the MRC's weekly report on deaths, most of the deaths at the moment are people between the ages of 50 and 65, rather than older, as you've said. But can you explain this comorbidities thing? What role does it play, and what's your advice to people out there at this moment who may or may not know whether they have a comorbidity that puts them at a greater risk of illness?
Yeah, I mean, you started off perhaps. So I mean, when you look at the curve in terms of where are the most deaths situated in terms of age, it's never going to be at the end. It's not going to be at the 80, 90-year-olds, just because we don't have many people who are 80 and 90-year-olds. But in terms of if you take 80 and 90-year-olds and you compare them to, say, 50-year-olds or 30-year-olds, the rate within that group is higher as you get older. So it's definitely a very bad thing to be, in terms of age is the biggest risk factor for COVID-19 by a long way. And it dwarfs all the other things. But in a country as young as ours, we're going to see a lot of comorbidities accounting for a lot of the death. And that's because, like I said, age is less of a factor in this country. And the kind of typical comorbidities are things like diabetes, hypertension, obesity, and lung disease, HIV to some degree too. So it's, as you said, it's most people who have these conditions do know about it, but many won't. If they may not know they have diabetes, and certainly COVID-19 can sometimes bring it out. So it's the first time you come to hospital with diabetes is during your COVID infection, and it's very difficult. I think that those at higher risk obviously need to take higher precautions and understand that while it is absolutely true that the total fatality ratio of cases here is low, in other words, that if you picked anyone out of the population to have COVID, the chances on average of them dying are probably under 1%. For people with higher risk conditions and people of over a certain age, it can be a lot higher, and they have to take higher precautions. That means staying away from crowded areas particularly, and we can come back and maybe talk about this a bit later, but the congregations of people are absolute nightmares in terms of COVID-19. And then the standard other things like face masks and keeping a social distance, and trying not to mingle with people where you don't have to. If it's possible, if you're lucky enough that you can order food and it arrives, or you can get someone to bring it for you, that's got to be better than going out to the supermarket to get it, especially if you have these comorbidities. And a bunch of other things similar to that. But really, those with comorbidities need to take greater precautions than those without.
Thank you. Nathi, anything to add on that?
I mean, from my side, it's more so a mechanistic thing, I think, because I think comorbidities probably speak more to, in some cases, reserve. And I think with sort of the morbidly obese, that's probably the perception. And then additionally, the pro-inflammatory or underlying sort of hyper-inflammatory states that these conditions actually produce. And I think obesity as well is known to be a pro-inflammatory condition. And that probably explains as well in part this whole vascular aspect of the disease and probably contributing to mortality. So people with comorbidities tend to be more prone to having these vascular events with thrombosis, strokes, and heart attacks, and so on. So I think that's where that picture probably emerges. And I think with the elderly, it's the same thing. So it's people that start with low reserve from the start. And when they get the disease, it actually just tips them over because then they can't sort of cope or manage to pull back sort of further reserves to actually get them through. And when you see young patients that are actually highly hypoxic, it makes sense why the very elderly cannot cope. When they're young and very hypoxic, they take more strain as well.
Thank you. Thank you very much. So Jeremy, because we're running out of time. What can we do to? We used to talk about flattening the curve. A moment ago, you talked about people's behaviors, going to the shops, congregating. I get the impression some of the time that people think that part of the lockdown meant that they don't need to practice these behaviors anymore. Are you saying that it's more important than ever that people did what they were doing between late March and early April, and now is not the time for people to be having braais and parties and shopping expeditions and everything else that goes with it?
Yeah, I am. That's a pretty good summary. I think, I mean, like Nathi said, I have to distinguish that from a lockdown. I don't think a lockdown is likely to achieve much at this point. I think there's so much community transmission that keeping people at home when it's very difficult to self-isolate, when you're living 3 or 4 people to a room sometimes, is just not a viable option. And the costs of it are enormous. Nonetheless, there's plenty of other things short of a lockdown which absolutely do help and which are relatively easy to do. Wearing a face mask in public helps. It helps, it prevents some degree of transmission, protects other people especially. And so that's something that you can do, preventing big congregations of people. And again, remember the peak risk period is this month or 2 from now in terms of Gauteng. So if ever there was a time to get it right, it's now. And I would support really walking back one aspect, and that's the agreement that, for example, people could congregate up to 50, or they could go to cinemas or places of worship. I just think for the next month or 2, those are bad ideas from a medical perspective. And I do think that if that could be stopped, at least for this critical period, that would help. And the risk is different. People don't appreciate if there's 2 of us in a room, my child versus 20, let's say. So if I go up from 2 to 20, my risk is not 10 times more, it's 100 times more in terms of getting that. So you can imagine how quickly it goes up with big groups. Keeping distances, and taxis taxis have to come down from 100% in my books, in terms of occupancy. There need to be 50% occupancy maximum with the windows open, get some good ventilation. That's a key area where people who have of lower socioeconomic status who have to take a taxi to work don't have an option, and they have to be protected as much as possible. Masks on taxis should be absolutely mandatory. In terms of separation, and like I said, keep people apart as much as possible for a meter or two wherever at work and in shops. The sort of things that we know about and are not a lockdown, but are all the things that are sustainable, that don't prevent people from earning a livelihood, that don't prevent people from getting on with their lives, but are just good sense. And then, as you rightly said, you've got to target that especially and understand the especially vulnerable. So the people over, say, 65 or people with lots of comorbidities. Those people have to be exceptionally careful, but it's not good enough for just them to be careful. If I'm young and healthy, I can't take the risk of getting COVID-19 now, not necessarily for me, but because I will spread it to someone who's not young and healthy and who's over the age of 65 or ill in some other way. So everyone has to pull finger about this, and they have to do it, just like I said, critically for the next month or so. If you get over that hump and the numbers start to come down, it will be a lot easier then to justify going back to something approaching normality gradually.
Thanks. So key takeaways, Jeremy, of what you've just said. People need to hear. This is peak risk period we're going into. It's not somebody else's problem, all these people now going to hospital. It's a time when you are more likely than ever to be infected with this virus, and therefore place yourself at risk. So take those messages seriously. And the second thing is that there are still things that we can do, that you can do, that I can do, and so on, that can mitigate and that can take the pressure off people like yourself and Nathi and the thousands of other healthcare workers who are battling with this on a day-to-day basis. Nathi, in 1 hour's time, just over, President Ramaphosa will speak. What would you be saying tonight if you were the president as to what our priorities have to be at this particular moment, and where your priorities as the president are in terms of getting this health system ready for what lies literally hours in front of us?
I think my screen is frozen. Hopefully you can still hear me though. So I think from my side, it's the appreciation and actually echoing Jeremy's last points. We are doing the reverse of what we should be doing, and we need to be aware of that. We unfortunately cannot undo that particular aspect, and we have to unfortunately continue with the trajectory and the path that we have set. But now we are going to be this for the long haul. This is not going to end sort of in October, November. It's probably going to hang around for longer. When the next winter period comes back, we're probably going to have another surge with this disease. Putting into place processes to get us ready is going to be paramount. So if we are not ready for this particular time, it is not the end of this. So when we start engaging the private players, when we start procuring more of the stuff that you're going to need for probably the second surge and so on, it needs to start happening now. Whatever we construct must be meaningful. So there is a whole take within the Gauteng Province, for example, of building more ICUs within certain institutions, but without realizing where staff is going to come from. So whatever we spend on at this particular time must make sense and must be something that we will use later on. Beyond that, we need to actually maximize an already available capacity. There is no point in building further hospitals if we don't have people to work in those hospitals. Question is like, how do we maximize access to the other areas where actually doctors are, nurses are, physiotherapists are, and so on and so forth, to make sure that the next wave does not have the same results as this one.
Thank you very much. I think those lots of wisdom, important things that you've just said that the President of the National Command Council, I hope will listen to. Jeremy, any parting thoughts from you? We're about to go 1 minute over time, but is there any particular message you want to put across before I close down this webinar and give people a chance to take an hour before sitting down to listen to the President?
So to the list I gave you, I can't believe it as an infectious disease doctor, but I forgot to mention about hand hygiene, so washing hands as frequently as possible too. But I think really, for the general public, the key thing is that this next month and a bit is going to be the critical crunch time around Gauteng, and just to get everything right as possible in terms of mitigating your own risk for yourself, but also for other people. And if you do those things, that's all we can possibly expect from the general public. And in terms of us, in terms of doctors and healthcare planners and government and advisors and NGOs, what we really have to get right is the number one thing, and I do think there's appreciation for this, but it has to come right, not just be appreciated, is that we need the number of beds to increase dramatically, including those available to give oxygen. If we can get that right, we'll have done well.
Thank you. Dr. Mdladla, is there anything you have to say before we go?
Glad you have been part of the webinar, and thanks for the invite. Nothing else for me to say.
Okay, well, from me, I just want to thank you both very much, not just on behalf of the Daily Maverick, but on behalf of all people in South Africa who are going to be heavily dependent on your sacrifice and your efforts and your investment in the future of this country. I also just want to thank every other healthcare worker who is out there alongside you. The nurses, the doctors, the people who work as porters, people who clean our hospitals, people who are manning the reception areas of hospitals. You are our heroes, and we are behind you, and we will try to do all we can to change our behaviors to make sure that we minimize what is coming through the system that you are going to have to manage. So thank you very much, and thank you once again to all of the listeners tonight. I'm sorry there were many questions that couldn't be answered. There's always many, many more questions than we're able to get through, but we will endeavor. We've seen all the questions. We will endeavor to answer them. And to all of you, take care, stay safe, think about yourself, think about other people, show solidarity, particularly with the poorest and the most vulnerable. And good night, and thank you. Thank you.